I will serve as your moderator for this evening's event. Welcome to Prostate Health, what you need to know. Before we delve into the subject matter today, I would like to give you a background in regards to the organization that is responsible for this event. Herbert Irving Comprehensive Cancer Center, Office of Community Outreach and Engagement, or COE. They are blessed with a magnificent staff that does a lot of work in the community. The mission of CEO is to reduce cancer burden and cancer in the communities served by the Cancer Center. Additionally, the COT is a team of community educators, outreach coordinators, and researchers who work with the community partners to create projects that address the health disparities in their neighborhoods, provide educational workshops and seminars for cancer, examine data on cancer trends in and around New York City, and identify areas with the greatest need. This organization opened in 1911 as the Institute for Cancer Research and received its National Cancer Institute designation in 1972 and was promoted to the comprehensive status in 1979. Next slide. Although we have been around for quite some time, we are still soliciting help. I'm inviting everyone present to accept an invitation to join a prostate cancer work group. And what we do is we collaborate with the community, working together with the community to do something about the high rate of prostate cancer among men in Harlem, creating and putting plans into action to create awareness to prostate cancer risks, to explain the importance of speaking with a doctor about prostate cancer risk, and to educate men about prostate cancer screening. What we will learn today: what the prostate gland is, where it is, meaning where it's located, and what it does. What problems can develop in the prostate, cancer of the prostate, screening of the prostate. Let me quote a few statistics so that you can better understand how prostate cancer affects men and their families. This is a chart that compares the national rate to New York's rates. This chart was established from 2012 to 2016 and rates per 100,000 men. In the United States, the rate is 104.2 for 100,000 men. In New York State, it's 125 for 1,000 men. In New York City, which includes the 5 boroughs, it's 126.1. In Washington Heights and Inwood, it's 172.5, and that is where the Cancer Institute is located. Hamilton Heights, West Harlem, is 169 per 100,000, and that's where I live. Central Harlem is 183.1, and East Harlem, 129. Prostate cancer by race, and this is very important. In this chart, we have the incident and we also have the mortality. Prostate cancer incident and mortality rate. In the United States, and I will do the incident rate chart first. In the United States, blacks is 179.9. Whites, our Caucasian brothers, is 97.2, and Asians, 52.5. In New York State, the incident rate is 196.7 for 100,000 men. For white, it's 114.7, and for Asians, it's 58.1. New York City, which consists of the 5 boroughs, blacks, 194.3, whites, 103.7, Asians 58.2. In Manhattan, where I also live and where the Cancer Institute is located, it's 192.4 for blacks, 104.2 for whites, and 51.6 for Caucasian. The next chart is the mortality rate, and this one is particularly painful to me because you will see that most of the statistics is double for blacks as opposed to whites. Mortality rate in the United States for blacks, 38.7, for whites, 18.7, Asians, 8.6. New York State for blacks, the mortality rate is 33.1, as opposed to our white counterparts, 16.2, and Asians, 5.5. New York City, which again consists of the 5 boroughs, for blacks, the death rate is 34.5, whites, 16.5, Asians, 5.8. And in Manhattan, the death rate for blacks, 33.2, for whites, 18, and for Asians, 5.7. Now we move into the part of the program that I guess most of you are interested in. We have 3 speakers. We have a prostate cancer survivor, and we have 2 urologists. First speaker will be the survivor, Mr. Otis Stewart. Mr. Otis Stewart is a resident of Birmingham, Alabama. He earned his bachelor's degree from Murray State University in Kentucky, Master's of Business Administration from Rutgers University in Newark, New Jersey, Doctor of Jurisprudence, Miles Law School in Birmingham, Alabama. He currently serves as law professor at Miles University in Birmingham, Alabama. Mr. Stewart is a tax attorney and CPA. Mr. Stewart utilized the same urologist that I did 25 years ago, Dr. Brian Stone, who at that time was employed by New York-Presbyterian. He has since moved his practice to Birmingham, Alabama, and Mr. Stewart is a client of him. Hello, Dr. Stone, if you're listening in. Mr. Stewart will walk you through his journey as a prostate cancer survivor. Mr. Stewart.
Thank you very much, Calvin. It's a pleasure to be with you guys tonight. Well, my journey was a long one because I had had so many friends that had been diagnosed with prostate cancer. I started to look for it many years ago. I've been going to urologists probably 25 or 30 years religiously, every year, sometimes twice a year. I was saying, well, when will my turn come up? Because I had so many friends around me that had found that they had prostate cancer. But about 2 years ago, I've been getting the PSA, the digital check, and everything else. And Brian, Dr. Stone, he's one of my Sunday school kids. I'm not that old, but I was that young, rather. And so when he moved back here, I started going to him immediately. And we've been friends. I know his parents. And so he checked me out and that'd be okay. About 10 years ago, he did a biopsy. It was benign at that time. Nothing was happening, but my PSA was gradually going up. So I was on the lookout. So about 2 years ago, he said, well, I think we may have found something. So he checked, and sure enough, that was prostate cancer was front and center. At that time, he gave me a couple of options in terms of what to do. I could get the surgery or do the radiation. I opted to do the radiation, and I did that. So it's been, I think, about 1.5 years now since the radiation. So far my PSA went down to like 1 point something, and so far everything has been okay, and the surgery was very successful. There was a little incontinence early on, but I thought I was good to go. It was early detection because I had been going religiously, and so far so good with me.
Thank you so much for your story. As I listen to you, your story is a little different from most men because they are reluctant to go to the doctor. And it was nice to hear that you went religiously on a yearly basis. And I won't tell my story, but my story is quite different from yours. Again, thank you. Next, we will have Dr. Joseph Aluka. He is the Director of Men's Health at Columbia University Irving Medical Center and Associate Professor in the Department of Urology at Columbia University of Physicians and Surgeons. He is a nationally and internationally expert in the fields of male infertility, male sexual dysfunction, and men's health. Dr. Luca earned his MD from North Carolina at Chapel Hill School of Medicine. He did his intern and completed his residency at Boston University Medical Center. I had the pleasure of working with Dr. Luca and find him to be very personable and very dedicated to his profession. Dr. Luca.
Calvin, thank you so much. It's really a special pleasure to be here tonight. And I'd also like to thank you, Mr. Stewart, for being willing to share your story with everyone. I know how important that is for the audience, and I know how difficult it can sometimes be for us to come forward and to tell these kinds of stories to people. So it's really, it's an honor to be here. Thank you guys so much. Give me just one moment. So we're going to talk for just a few moments about the prostate. Calvin's already given us an excellent introduction to this topic and some really relevant statistics. And one of the things in there that jumped out at me is, there's a lot there that we have to work on still. There's certainly lots of questions that I think are important when we try and figure out why it is that more Black men are getting prostate cancer and more Black men are dying of prostate cancer. But one thing in there, if we're trying to look for the positive that really jumped out at me, looks like we're doing a better job keeping people alive in New York State and New York City and Manhattan than maybe we are in the rest of the country. So, we're doing something right. Dr. Hyams, who's going to speak next, is a world's expert in the management of prostate cancer specifically, and he's going to talk to you a bit about the specifics of how you handle the disease. I just want to give you a quick overview and talk to you a little bit about the prostate. But first, the topic we're talking about, we are talking about the most common solid cancer that occurs in men. And as Mr. Stewart alluded to, our treatment options, broadly thinking, they include surgery and various surgical techniques, and they include radiation administered in different ways. And we're going to delve into that in a little bit more detail, Dr. Hyams will specifically. We know that both these treatments in men can cause problems with being able to get an erection. And that's probably, I think, the biggest thing that keeps men from coming into the doctor is this fear. And I'll focus on that a little bit more. And this is, another way of putting Mr. Martin's statistics out there. This is a very common disease. It's give or take about 200,000 men every year in the United States who get a new diagnosis of prostate cancer. But we suspect that it affects as many as 2+ million men in the entire country right now. So certainly this is something that a lot of people are dealing with, and we need to continue to focus attention on this disease. Let's learn a little bit about the prostate itself. I always make the same joke with patients that patient in front of me, myself, every man on this planet, the only job our prostate has other than to cause us trouble as we get older, it's to make the fluid that goes into semen and to ejaculate it. Now that sounds strange, but like everything else in our bodies, an organ has a purpose. And this particular purpose turns out to be really important to us, both in the experience and the enjoyment of sex, but more importantly, and that's how I've ended up learning about this and talking to people about this, in terms of a man's ability to father his children. And so the prostate is kind of grand central for a lot of things that are sort of meeting in our bodies, including the tubes that are enabling us to urinate or to have an ejaculation, the tubes that carry sperm from our testicles, and the prostate itself is making that fluid that goes into semen. So it's a gland, and it turns out that humans aren't the only animals that have this gland. Like I said, it's only got this one particular function, making this fluid and then enabling the event, an ejaculation that expels this fluid with semen inside of it. But certainly it can cause a lot of issues in men, not just prostate cancer. And we'll talk about that for just a moment. Where is this organ? It's deep in our pelvis. Okay, so this is a cartoon, obviously, but here we have a cross section of a man's pelvis, and we can see the bladder. And behind it, we can see the colon and the rectum and the anus. Here's the prostate beneath the bladder. Here's the pubic bone. And then here's the urethra, this tube that we pee out of, and the base of the penis. And so I put this up here not to make people uncomfortable, but to explain to them why it is that some of the uncomfortable things that happen in a urologist's office have to happen. As Mr. Martin alluded to when he was talking about Mr. Stewart's experience and Mr. Stewart's willingness to come in and to get seen and to get checked, and so many men aren't interested in doing that because they're afraid of getting examined by a doctor like myself or Dr. Hyams. And believe me, it's no fun for us either. But the way I always put this to patients is, look, you know, it's a couple uncomfortable moments, but what you get is a year's worth of peace of mind. We really ought to just do it. And what we have to do is we put our finger in there inside the patient's rectum in order to feel one surface of the prostate with our gloved finger. What are we feeling for? We are feeling for lumps and bumps. We're feeling for the growth of the prostate. All of us as men throughout our lives, our prostate does something strange to us. You know, a young man goes through puberty and his prostate starts off, it's very small. Maybe it's the size of an olive, it might be smaller. And as he goes through puberty and all these changes are going on in his body, his voice gets deeper, he starts to grow body hair, he starts thinking about sex. All of these functions wake up in his testicles, his penis, his prostate, and his prostate starts to grow. Now, the interesting and confusing thing is that young man, when he gets to 18, 19, 20, his body stops growing. And some of those changes stop being quite so pronounced. And he starts to get control of some of these urges that were causing him to get erections in math class that he didn't want, or to eat everything inside, or to grow like a weed. All those things slow down and his body stops growing, with the exception of his dumb prostate. At that age, at 20, his prostate is probably maybe the size of a walnut. Sometimes in our practice, in a man in his 80s or 90s, we might take out a prostate the size of a grapefruit just because that gentleman can't urinate. It doesn't necessarily mean he has cancer. And so this crazy organ keeps growing over the course of your whole life when everything else stops growing. Why, we don't know. How, we understand, and that gives us some tools to treat prostate growth. But yes, examining the prostate is one way for us to figure out how big or small a gentleman's prostate is, as well as his risk of prostate cancer. So this is a cartoon of something else. This is actually the event that occurs when a man is going to be diagnosed with prostate cancer. He has to undergo an ultrasound-guided biopsy of his prostate. So we're looking at the same anatomy. Here again is the bladder. Here again is the colon and the rectum. And this time, instead of the doctor's gloved finger, we have in there an ultrasound probe. And passed through the ultrasound probe is a needle that can take samples of the prostate. And so this is why, you know, again, something that men are afraid to undergo. They don't want to talk about this kind of a procedure. But this procedure is how we will diagnose prostate cancer in a man where we suspect it. And, you know, as it currently stands, we don't have anything that is able for, you know, to do away with this procedure yet. We worry when men undergo this about their risk of infection. We do a lot of things to try and keep men from getting infections in the aftermath of one of these biopsies. We expect that men might have to deal with some blood in their urine or their semen for a little while after the procedure. And sometimes that can cause a complication, in that it might make it difficult on a man to pee, or make it impossible for him to pee if he's passing too much blood. So then sometimes those men come back in as an emergency. But what I don't want people to be worried about, people are always asking me about the chance that a biopsy is going to cause their cancer to spread. And I just remind people, look, this is the only way we have to diagnose prostate cancer. If it always caused somebody's cancer to spread, no one would ever be cured. You know, you can't take out somebody's prostate with surgery if his cancer's already spread and expect that you're going to cure him. And instead, we cure an overwhelming majority of men with prostate cancer. So a biopsy might be something that you have to go through, but it won't be the end of the world if it happens, and it's not going to cause your cancer to spread. And this is just an image, whereas before I was showing you cartoons, this is actually an image using a very powerful MRI that shows you the prostate in the bottom of the patient's pelvis. Up here is his belly. You can see, you know, the part of his abdominal wall that would get stronger if he does sit-ups. Behind it, his pubis, a little bit of that bone that we talked about, his pubic bone. And then here in the pelvis, some muscles. Back here, the rectum, the anus, and here's the prostate sitting there and, like I said, you know, causing us trouble. So what are some of those other conditions that can bring a man into a urologist's office and cause him bother? Certainly that growth of his prostate, like I alluded to, it's going to eventually cause almost all gentlemen some problems with urination. Men will tell you things like, oh man, I can't pee the way I used to. I don't write my name in the snow anymore. I wake up at night to pee. I have urges to go pee, and then sometimes nothing comes out. And when I do pee, it dribbles out. These things are the kind of things that should prompt a man to talk to a urologist, either about medicine that can sometimes help with that, or surgical procedures that can sometimes help with that. And this is a common problem. This by itself, not prostate cancer, this results in 500,000 visits to the doctor every year in the United States. Some men can get inflammation of the prostate, which can cause them pain. Sometimes that can actually be part of an infection that's going on at the same time. It can be really bothersome to patients, and sometimes it can be difficult to treat. Prostate cancer, certainly we've talked about already. And the part of this that I think is important, you know, we're going to talk a little bit more about this, and again, Dr. Hyams is a real expert. But if we're talking about screening people for prostate cancer, you know, and we're putting our finger back there to feel that the prostate feels normal to us, the other thing we're using is a blood test called a PSA. And one of the confusions that arises with PSA testing is that all of these conditions, an enlargement without cancer, inflammation in the prostate, or cancer itself, can cause somebody's PSA to go up. How do we know who is who or who has to worry? That's part of what the urologist has to figure out. So to talk a little bit more about it for just 1 second, what is PSA? It's a blood test, and it's measuring a compound that only gets made in your body inside the prostate. It has something to do with semen functioning normally in terms of your ability to get a woman pregnant. And some of it gets out into our bloodstream and can be measured with this blood test. That test, PSA testing, really only came to pass in the 1980s after some research that had been done in the 70s. And in the late 1980s, it became more widespread that PSA testing was performed. And a lot of research looks at the idea that an elevated PSA can tell us something about a patient's risk of prostate cancer, but it doesn't always mean that the patient has cancer. And that's part of the confusion of this test. And a lot of the confusion that I encounter when patients are talking to me about this test. We used to say to everybody that a PSA less than 4 was normal. With time, we eventually figured out that that was still actually missing a reasonable number of prostate cancers. And so for some period of time, we lowered that number, and then we started thinking about the idea that maybe we needed to make age-appropriate ranges, that maybe a PSA of 2 or 3 makes perfectly good sense in a 70-year-old man, but it doesn't make good sense in a 45-year-old man. And then there's other things that we've done to try and help us use PSA to specifically identify only men with a higher risk of prostate cancer. So is a man's PSA changing or increasing too fast? You know, last year was 1.5, but this year it's 2.5. Well, on the one hand, both those numbers are low, but on the other hand, those numbers are moving pretty quick. Do I need to be a little bit more worried about the possibility that this gentleman has a prostate cancer? I have to put that in context of things like his race, as Calvin alluded to with his statistics, his family history of prostate cancer. Does he have brothers or his father or his grandfather or his uncles who have prostate cancer that he knows about? Sometimes his son. I've seen that before over the years. And so in those cases, having things that make me believe that the patient's at higher risk plus a rapidly moving PSA might prompt me to tell a patient, hey, we really need to look into this sooner rather than later. As well, there's something called a free PSA, which can help us to identify some men whose PSA elevation is even more likely to be due to prostate cancer than otherwise. And these are all tests that your urologist or your internist can order. So some last thoughts. They asked me to really talk and focus about myths, things that I know patients would be better off understanding weren't true about their prostate. And these are all things that I promise you I've heard before many, many, many times from many, many different patients. First, somebody who doesn't want me to examine their prostate. Doctor, I thought nobody needs to have a prostate exam anymore because the blood test is good enough, right? Well, I hate to say it, but the bad news is that both that exam and the blood test aren't perfect. But when you put the two of them together, you do have a reasonably good way to effectively screen somebody for prostate cancer. You do have to do both. And I tell people, if we're going to screen you for prostate cancer, if we're going to make that decision, we probably need to be doing those tests once a year. Doctor, why are we looking into this? I don't think anybody dies anymore from prostate cancer anyway. That's not true. And certainly Calvin's statistics bear that out. You know, what was he talking about? He's talking about 30 men, give or take, out of 100,000, if they're African American and they have prostate cancer, who are dying every year of prostate cancer. That is still way too many. That's twice as many as the comparable Caucasians diagnosed with prostate cancer each year in the United States, and even more than that than Asians and Asian Americans. Why is this disease disproportionately affecting Black men? We don't yet have the answer to that, but we do know that some part of it is a generalized desire to avoid screening in the part of the African American community. People like Calvin and Mr. Stewart are fighting to grow awareness about this disease. And what we hope to do is to help people understand, hey, I don't have to be afraid of getting screened for this disease. Nothing bad is going to happen to me just to go in and have this conversation with my doctor and to undergo these tests. I already addressed this one. People who are worried about getting a biopsy, who tell me, you know, doctor, I'm worried that the biopsy is going to actually cause my cancer to spread. Again, like I said, not true. If that were the case, we'd never be able to cure anybody either with surgery or radiation. And then lastly, this is the biggest one and the toughest one. If I get treated for prostate cancer, I won't be a man anymore. And this is the way men say it to me when they're worried about the change in their sexual function, the fact that by getting treated, they may not be able to have erections in the future the way they recall having them before. But for starters, a lot has been done to actually make it such that men undergoing surgery or radiation today are less likely to have problems with erections as a result. More importantly, doctors like myself absolutely have a ton of tools in our toolbox for getting men after treatment for prostate cancer to be able to have erections again. So this is something that can be solved. Problems with erections after treatment for prostate cancer can be solved. But the other point I would always make is, who's ever going to look at their family members and say, well, I avoided getting treated for this disease, and as a result now I'm hospitalized, I'm ill, I'm dying, and I'm going to leave you guys behind, my loved ones, my children, my spouse, my parents, my siblings. Who's ever going to say that they're being a man by doing that? The opposite, confronting this disease, treating it, and surviving, to be there, to be a part of your family, to be support for your family, is being a man. And if instead you're dealing with this one problem after getting treated, I promise you I can solve that for you. I'll figure out a way to make your sex life real again. But you need to get treated for this disease if you want to actually stand up and be a man for the people who love you. Okay, I've rambled enough. I'm happy to take any questions, but I think Dr. Hyams is gonna talk first, and then we'll be here to answer any questions afterwards. And again, I want to thank everyone so much for this opportunity to talk tonight.
Thank you, Dr. Luca. Yes, Dr. Hyams will go next. Then I will show a slide for some referrals, thank a couple of people, and then we will go into questions and answers. Dr. Elijah Hyams, MD, is Associate Professor of Urologist at Columbia University Medical Center, specializing in diagnosis and treatment of various urological cancers, male voiding dysfunction, and urinary tract obstruction. Dr. Hyams performed a high volume of robotic prostatectomies, a minimum invasive procedure to reduce morbidity and hasten recovery following prostate cancer treatment. Dr. Hyams received his MD from the University of Pennsylvania in Philadelphia, then completed a urology residency at York Langhorne Medical Center in New York, New York. Dr. Hyams.
Great, thank you very much for the invitation to speak tonight, to share some information, and to follow Joe to give a little bit of a deeper dive into, the ways we diagnose prostate cancer and the ways in which we treat prostate cancer. And I'll try to go fairly briskly so we can get to some questions and answers toward the end. So Kimberly, thank you. So you can just click through the slide. So what is prostate cancer? So the cancer is, when cells that are otherwise normal and grow gradually or stable grow rapidly and proliferate. So that can happen really in any cells in the body, and it can certainly happen in the prostate. There are some very clear risk factors for developing prostate cancer. Really the most significant is age. So older men are more likely to develop prostate cancer than younger men, and that helps us target particular age ranges for screening and early detection. Ethnicity is a really critical risk factor, and you've heard this through the evening so far. African American men have the highest risk of developing prostate cancer generally, and also having a more aggressive type of prostate cancer. Furthermore, they have a greater risk of dying from prostate cancer, and it's not clear precisely why that's true. It is thought to be a combination of maybe genetic predispositions, environmental exposures, access to healthcare at times, that sort of thing. Family history is a really important risk factor as well. Specifically, so when you think of family history, it's important to hone in on that. So it's not just having, a great uncle, on one side with prostate cancer at age 90. It's really specifically having a first-degree relative, a brother or a father, diagnosed with an aggressive type of prostate cancer at a younger age, which is usually considered less than age 65. If someone has one or more relatives like that's a real sort of riskier situation. Those men need more attention. Also, what's really only recently been discussed more is that having multiple relatives with breast, pancreatic, or ovarian cancer can convey risk to a man of developing an aggressive prostate cancer. So it's really important that it's really not just history of prostate cancer in the family, but those other malignancies as well. So people have worked hard over many years to see how can we prevent prostate cancer from forming either with medication or diet or behaviors, what have you. And unfortunately, there's no specific prevention approach that's been validated. Another challenge here is that most men with prostate cancer, particularly when it's present early, don't have symptoms. So the concern is that symptoms like blood in the urine, urinary tract obstruction, weight loss, things like that, pain in the bones or back, sadly are late manifestations of prostate cancer. If you wait for those to arise, you're going to be too late at detecting and intervening to prevent harm. So that leads to the need for screening, which is really testing men who have no symptoms to see if they're at increased risk. Next slide. So I won't belabor this, but prostate cancer is quite common, and it's a common cause of death in men. It's actually the second leading cancer cause of death in men after lung cancer. Next slide. So prostate cancer has diverse behavior. So what we're trying to do as urologists, as physicians and providers, is to find the aggressive types of prostate cancer. So, many prostate cancers, and you may have heard this, are slow growing. In fact, most of prostate cancers are slow growing, and men will often die with rather than from prostate cancer, and that's fine. That means that prostate cancer never caused symptoms, never caused death. It's just incidental to the aging process. The cells in the prostate, as you age, they can start to grow, and if they're growing inappropriately but very slowly, that's fine. If men are living into their 80s, 90s, or beyond, and dying from other causes that, or other more significant health problems, that's fine. Our job is to identify the men who are at risk of developing symptoms or death from prostate cancer. And while it's just a subset of men, those men obviously can suffer greatly and can be significantly harmed. And that's why we do screening and early detection. And our job as urologists is to separate or better understand for a man whether he's at increased risk for one of the more aggressive cancers versus just one of the age-related slow-growing cancers. And we have many tools to do that. Next slide. So again, the challenge is to identify those potentially dangerous cancers in a window of curability. You don't want to get there too late, but you also, in our earnest effort to find problematic prostate cancer, we don't want to find a ton of those slow-growing cancers where, frankly, all we've done in that case, and if a man's not destined to have any problem from that incidental change in their prostate, we can make them a cancer patient. We can introduce anxiety, additional invasive testing that's not needed, and potentially treatment that's not needed either that can have side effects. So, but next slide. This, I think, is the way I think of prostate cancers. I think this is a useful paradigm. So there are prostate cancers that are like birds and just sort of fly away rapidly. And, even with earnest screening at a young age, we're not going to be able to identify and catch them. Fortunately, that's a very small minority of prostate cancers, though that does happen. On the other hand, there are the turtles, the very slow growing ones that are age related. We're not looking for those. Those are not going to cause harm. We're looking for the bunny rabbits in the middle that are hopping around that can jump out of the pen at any moment. We want to identify and intervene before that's occurred. Next slide. So our primary screening tools are, as Joe mentioned, PSA and digital rectal exam. And I really won't belabor the point on these. You know what these are at this point. Our screening, which is use of these tools to identify prostate cancer early, before symptoms, before risk, real tangible risk. These efforts to screen men have gone on for a long time. In fact, the PSA arrived in the late 1980s and was used as a tool for early detection. What happened was that it helped to find more cancers, absolutely. And actually, we've seen a decrease in metastatic disease and prostate cancer mortality significantly since then. But we also saw a significant increase in diagnosis and detection and diagnosis of the slow-growing cancers. So that's the challenge. We want to be careful in our efforts, and very tailored and careful in our efforts to identify, again, the more dangerous cancers and not do what we call overdiagnosis. And that's our job as urologists, and a ton of thought and research has gone into this, and I think we actually do a pretty good job. Please keep going. So just a couple principles of screening and early detection, sort of what's the contemporary approach in 2020. Well, first and foremost, when men are referred to for discussion, or when they were their primary care doctors, and we're talking about prostate cancer screening, it's important to do what's called shared decision-making. So rather than just ordering a test for a patient, it's important to have a discussion about what's the utility of it, what are some potential risks of it, and engaging men in that decision-making process for screening is actually an important thing, and it's an important principle in all of the screening guidelines that exist. I'm a firm believer in screening and having discussions and starting the process of understanding a man's risk, and that often does start with PSA. So to be more sort of tailored with our approach, we do, and this is reflected in guidelines from different organizations, what's called risk-based screening. So we focus our efforts on men in a certain age range, typically, depending on risk factors, starting in 40s to 50s, with PSA and digital rectal exams. African-American men absolutely warrant more attention at an earlier age based on risk, family history as well. And health status is important. So as men get older than age 70, 75 or beyond, or have other competing health risks that maybe make their life expectancy less, like less than 5 years or less than 10 years, screening has not been shown to be helpful in that setting. So all of these things go into the discussion. Joe mentioned that, we are able to use tools beyond PSA. That's absolutely true. And this is the bread and butter of my practice. It's seeing a man with an elevated PSA. PSA is an incredibly useful initial screening tool to capture the men who are at increased risk. It doesn't mean that a man has prostate cancer, just like Joe said, but it means that he's at increased risk and needs to see a urologist for a conversation and for further testing. That testing is typically not invasive to start. It usually involves a discussion of risk factors and interpretation of PSA based on the size of the prostate, based on other things, urinary symptoms. Furthermore, we move along through the PSA if we're convinced there is increased risk to other blood tests, urine tests, or imaging tests like MRI, all of which are non-invasive, which give very good, useful, and accurate information about risk of prostate cancer. They don't make a diagnosis, but all of these tools help us decide who really needs to have a biopsy, who is truly at increased risk. And all of these tools have allowed us to eliminate biopsies and not require biopsies for a third to up to a half of men who come in with elevated PSA because of our ability to have a deeper understanding of their risk and avoid invasive procedures unless absolutely necessary. Next slide. So this is just a sample set of guidelines, which you can find online if you type in American Cancer Society PSA screening. So it just shows that based on evidence and their expert opinions, that for men at average risk who, again, are not African-American or don't have family histories and are going to live more than 10 years with the doctor's estimation, starting discussions of screening and possibly screening at age 50 is appropriate. And then as you start adding risk factors of ethnicity and family history, dialing that back to 45 or even 40 is useful and helpful for early detection. Informed discussion or shared decision-making, so important to engage patients in a discussion of risks and benefits of testing from the screening decision up through treatment decisions thereafter. And the ACS, American Cancer Society, discourages screening in men over the age of 75 because there is some evidence that screening men who are older does not help with meaningful detection of prostate cancer, really just increased risks of over-detection and increased anxiety and unnecessary procedures, etc. But I think that we should be careful about a one-size-fits-all approach, and there certainly are men who have extra risk factors or who have family longevity or real interest in screening who should be screened past the age of 75. Next slide. So these are just, I think, some useful tenets of treatment for prostate cancer. The next slide, we'll go over briefly types of treatments. But these are some things that have been done, that have been implemented over time to help us do a better job of only treating prostate cancers that need to be treated and ensuring those who are treated as best possible with the type of treatment that is sort of most appropriate for them given their preferences, wants, and the nature of their cancer, and also to optimize outcomes. So number one is to observe and not treat low-risk prostate cancer. Really, really critical point. So in the course of looking for the more aggressive types of prostate cancer, not infrequently we find low-risk or slow-growing prostate cancer. And we have a very mature experience with what's called active surveillance, where we monitor and don't treat aggressively low-risk, slow-growing prostate cancer. And that allows men to safely avoid the side effects of treatment while still carefully monitoring their cancer. And there's excellent evidence that those men have no increased risk of developing problems, and a significant proportion of them will never need to be treated. Really, really important. Historically, all men with any diagnosis would be treated with a one-size-fits-all approach, and that's not true today. Number two is to regionalize care. What does that mean? Well, it means that, in particularly for surgery, but this holds true for radiation therapy as well, a man who's diagnosed should be treated by an expert, by someone who does that at a high volume as the focus of their practice. There's very good evidence that for surgery in particular, seeing someone who does a lot of that operation on a regular basis allows for a higher likelihood of cure and better outcomes in terms of recovering erections and urinary control, that sort of thing. So I think that that's important. Finally, I mentioned shared decision-making earlier for screening, PSA testing, that sort of thing. I think it's as critical for engaging men who've been diagnosed with prostate cancer to help them understand what their options are, what the risks and benefits of those options are, and help them arrive at the best decision for them. So part of this is what's called multidisciplinary care, which is, and this is true at Columbia, men who are diagnosed see myself or one of my partners who does prostate surgery, robotic prostatectomy, a radiation oncologist who can do seed therapy, external beam therapy, other types of radiation therapy, and not infrequently a medical oncologist who can discuss hormone therapy or other types of treatments. And we work collaboratively, and we help counsel men sort of as an organic unit to help them, again, get the most appropriate treatment for them based on their diagnosis and their wants and preferences, because the logistics of these treatments, some of the side effects of the treatments are different. And it's, again, very important to individualize the discussion for an individual. Next slide. So this is just a brief overview of treatment options. So the things that we talk about is sort of the first line treatments for a newly diagnosed prostate cancer that does need to be treated, that's not appropriate for observation, would be a radical prostatectomy, which is surgery. Typically, this is done by a laparoscopic robotic surgery with small incisions rather than a larger incision. Though the latter can still be done, the first has been shown to have less risk of bleeding and have therapy comes in various forms. There's external beam therapy, sort of a word salad of IMRT, SBRT, CyberKnife, different types of radiation therapy, all variations on the theme of beaming and radiation to treat the prostate.
Oh, we're having a hard time hearing you, Dr. Elias.
What's what are called ablative therapies, which is typically for earlier prostate cancers. One could place a probe in the prostate to destroy one or another portion of it to treat cancer in that less invasive way. This is still considered investigational, though it is offered to some men and can be part of the conversation. Advance one more. There should be, there we go. So that's just,
Dr. Elias, we're having
a hard time. I think this is particularly critical for, patients as consumers. Can you still hear me?
Yeah, I think we missed a little bit of what you just said on this slide because your microphone cut out, but it's back on.
It's very faint right now. I apologize. Can you hear me?
Yes, we can hear you.
Okay, I'm going to keep talking even though I don't think I can hear you particularly well. So there are these different treatment options, and really I think it's important for men who are newly diagnosed to learn about all of them and to have providers who are open-minded and are listening to you about what your priorities are in terms of treatment, in terms of which side effects maybe are more concerning or less concerning. And it's really critical that men understand that this is a trade-off. So treating aggressive cancer is critically important to avoid problems, but there are side effects such as erectile, sexual function, and urinary dysfunction that can ensue from any of them. And as Joe mentioned, we work very hard, and I think actually we do an excellent job of setting men's expectations accurately so they know what may happen, and minimizing risk to them afterward, so that, for frankly most men, the urinary dysfunction afterward in terms of leakage issues or other urinary problems, it's only a small percentage of men who have durable issues with that, because we're able to counsel men through their recovery and help them recover typically fully in terms of urinary control. And in terms of erectile and sexual dysfunction, it varies a lot from man to man, but with techniques such as nerve-sparing surgery and different techniques with radiation therapy, we're able to minimize risk to erectile function. And certainly men do as well as they ever have in terms of regaining that function. That may be the last slide. You could advance, please.
Okay, I'd like to thank all the presenters very much. They did a very thorough job and has made this program very informative. I would just like to read one text that I just received from someone that's tuned in. It states, "This presentation is great, very informative, and the visuals are very helpful. The doctors are going at a great pace." Thank you so much for all that you continue to do. Next slide. If I know everyone has a cell phone, we'll have a screen that will give you some referral sites. You could just take a snapshot of this referral sites, screening referral sites.
Can you see it?
Please, yes, it's up now. Please take a snapshot of that. Thank you. I would like to thank some of our sponsors. We have a number of folk that help us put this program on. We have HCCI, which is Harlem Congressional and Community Improvement. We have Black Health, National Black Leadership Commission on Health, CUNYSPH, the Graduate School of Public Health and Health Policies, and we have the Prince Hall Medical Foundation. In terms of religious institutions, we have Convent Avenue Baptist Church, First Corinthian Baptist Church, Paradise Baptist Church, St. John's Baptist Church, First Bethel AME Church, New Springfield Missionary Baptist Church. We would like to thank each of you from the deepest recesses of our hearts. Now we can go to the Q&A session.
Wonderful. Do you want me to read out the questions?
Please.
Okay. Okay, first question is, prostate cancer used to be referred to as the slowest developing cancer of them all. Since then, it has been discussed that there is a more aggressive form of prostate cancer. How can you tell the difference?
Yeah, so it's both. It can be a slow growing cancer, and most prostate cancers are slow growing, and it's a subset of them that are more aggressive and can cause symptoms and death. So to differentiate between them, we use tools like the blood and urine test that I alluded to that go beyond PSA, that don't just look at risk of prostate cancer generally, but risk of what's called high grade or more aggressive prostate cancer. So those tools help us hone in on the men who have increased risk of the bad type. Then when we do a biopsy, there's a score assigned to a prostate cancer that's called a Gleason score. And whether that number is lower or higher also reflects the risk of the cancer. And so those are the ways that we sort of help identify men who are at risk for and then have the more aggressive type.
Wonderful. I can just remind everyone who's tuning in, if you do have a question, you can write it in the question and answer box at the bottom of your screen, or I think you can type it in the chat. I'll read the next question. Is the reluctance of African American men to get a prostate screening because of fear of doctors and the Tuskegee Institution experiments in the past?
I can tackle that question. I mean, I'm sure that has to play a role in people's distrust of physicians, and obviously the Tuskegee experiments, that's just a reprehensible chapter in American history. I've talked to people about this before and just tried to reiterate the idea that I think there's an awful lot of things in medicine that we are attempting to do to recreate trust with our patients, all patients, but including African-American patients. Much of what Dr. Hyams spoke about are the things that are occurring in modern medicine that are really focused on the patient. The notion that making a decision about being screened for prostate cancer or treating prostate cancer is something that the doctor and the patient do together. The doctor does not just tell the patient, this is what you're doing. That comes from an effort to try and make patients feel comfortable being part of the process and drive the process, because ultimately it's their life and their body. They get to choose. But to speak specifically to Tuskegee, I would just say that anybody in the year 2020 who's using that as an excuse to not get screened, all you're doing is you're giving that event more power over you now. You know, it's only going to negatively impact your health if you want to create excuses for not coming in, or if you want to point to that specific event. I promise you, we're doing our best to take good care of people. Don't let that interfere with you coming in to see the doctor.
I would add, because I think this is really important. It's just so helpful to have a good relationship with your doctor and to trust your doctor, and that having a longitudinal relationship is certainly helpful. Not everyone can have that if they're moving, or depending on what doctors are near, which doctors are nearby. But good primary care doctors will definitely take a moment and discuss that screening with their patients. Good urologists will take a moment, rather than rushing through and saying you need X, Y, or Z test. They'll take a moment and say, these are our options. What are your priorities here, and how can we move forward kind of together and make a joint decision about which test to do. You can't control that necessarily, the quality of the relationship you have with your doctor, your primary care, your doctor, or urologist. But I think those are important things to cultivate and to look for, for oneself and one's family.
I'll keep reading. We have a lot of questions coming in. How often do you recommend men with low risk prostate cancer get checked or evaluated?
There are different protocols for what's called active surveillance or monitoring of low risk prostate cancer. Typically men come in every 6 months for a PSA and an examination. If a man is diagnosed with a low risk cancer, we'll typically do another MRI and biopsy within a year of the initial diagnosis to make sure that we haven't underestimated anything with their prostate cancer. And if we confirm that indeed they have a low risk prostate cancer, then they're followed less intensively, and they still will come in every 6 months for blood work, examination, and discussion, but we don't repeat biopsies that frequently. We space it out every, not uncommonly, every 2 to 3 years initially, and then every 3 to 5 years afterward, until men reach a more advanced stage where it's not relevant anymore to their health. So that's the average sort of protocol.
Okay, this is another question. Oh.
No, I'm hearing that we have a lot of questions. I just want the audience to know, if we don't get to answer all of your questions tonight, the next slide will have an email address that we can forward the answers to your questions to you. I don't know how much more time we have, but let's keep going.
Okay, yeah, and we'll be happy to share the answers to all the questions that we don't get to in an email to everyone who attended. I'll get to the next question. I turned 56 years old today, no family history of prostate cancers, and I was diagnosed last Wednesday. I had no symptoms or signs of prostate issues, only found out after taking a medical exam for additional life insurance. First PSA level 14.5, second reading 16. I had an ultrasound and biopsy that came back intermediate risk with cancer contained within the prostate wall, and a Gleason score of 7 - 4 + 3 with some abnormalities in the lymph nodes. I think that's the end of the question. So I'm not sure if there's anything else.
Yeah, I mean, one challenge here is that, I mean, this gentleman didn't have additional risk factors. So this is why screening is so important. And screening guidelines vary. The American Cancer Society would suggest age 50 would be a better time to start screening. The urology guidelines, which our professional organization actually recommends starting screening at age 55 for average risk men without risk factors. So, you know, it just shows the challenge here of early diagnosis, and I think the importance of attempted early detection. This prostate, I mean, it's very case by case. You know, this sounds like a very treatable prostate cancer, and you know, I think just having a good urologist and multidisciplinary team would be the way to approach this best.
Okay, next question. At what age should a man with a family history of prostate issues / cancer start screening? My issues started at 22 years old.
I'll tackle that question in that I see a lot of young people with benign issues in their prostate. With a family history, there isn't a clear-cut discussion, Dr. Hyams, or a clear-cut answer. Dr. Hyams put up a slide with the American Cancer Society recommendations, and we used to have some clearer recommendations from our own governing body, the American Urological Association. But I'm usually going to tell that patient that we're going to start having this discussion no sooner than age 40. And even then, you're going to hear different answers for what should somebody in their 40s do. Do we wait until 45? Do we check one in their early 40s? And if it's normal, a PSA that is, if it's normal, do we wait again until their late 40s or age 50 before we check an additional PSA? And unfortunately, those patients should be undergoing a yearly physical exam of the prostate. So we can come up with a tailored screening approach that makes sense given that the exact nature of that patient's family history, any symptoms he might have, his age, his ethnicity.
Great, thank you. What is the difference between urology and oncology? Also, can the recording of the presentation be shared? Yes, the recording of the presentation will be shared.
Yeah, I mean, urology is a broad field covering the male and female urinary system and the male reproductive system. So a subset of urology is a treatment of, again, a wide array of problems: kidney stones, urinary dysfunction, cancers of the urinary tract, male genital system. A subset of urology is in what's called urologic oncology, which is typically surgical treatment of urinary tract cancers, like kidney, prostate, bladder cancer most frequently. When one says oncology, it's a general term for study of cancer, but that generally refers to what are called medical oncologists, which are doctors that we collaborate with who don't do surgery and don't do procedures typically, but do medical treatment of cancer. So hormone therapy, chemotherapy, things like that. You may hear about radiation oncology. Again, it's treatment and study of cancer, but through the lens of radiation therapy. So different types of oncology providers, but with different backgrounds and focuses, who can collaborate: urologic, radiation, and medical oncology.
Thank you. The next question, Dr. Elias, can you briefly expound on what ablative alternatives are?
Sure. The two primary ones are what's called cryotherapy, which is placing a probe in the prostate to destroy a portion of the prostate, or half of it, or the entire prostate, depending on the situation. A needle typically goes across the skin behind the scrotum, what's called the perineum, in a procedure done under anesthesia. And there is some evidence that that can be an effective treatment for low risk or early types of prostate cancer. Another type of ablative therapy is something called high intensity focused ultrasound, or HIFU, which is considered investigational in the United States, though it's done more commonly in Europe and in other countries. And it's a similar premise of placing a probe in one or more areas of the prostate to destroy it more with thermal energy or focused ultrasound waves rather than cryotherapy. But ablation is really destruction, and it's with different types of energy, and it's done through the same sort of approach across the perineal skin. So, you know, these are in my opinion, not effective for high grade or more aggressive types of prostate cancers, investigational for that purpose, effective potentially for earlier prostate cancers, But observation and active surveillance is also appropriate for many of those early prostate cancers. So I think there is a subset of men, I think it's relatively small, for whom those are good therapies, good treatments. The goal of them is to avoid a bigger operation or radiation therapy where there's greater risk of side effects. But, and this is critical, there's no free lunch, as I showed in my slide. So there is still a risk of urinary dysfunction, scar tissue in the urethra, and other problems associated with ablative therapies. Furthermore, and this is just my bent, if it's used inappropriately in men with more aggressive cancer, it can make future treatment of a recurrent or persistent cancer more difficult by causing scarring in and around the prostate. So again, I think carefully selected men may be appropriate candidates for that. And we have, Dr. Wensky in our group does cryotherapy and HIFU and does an excellent job both for some men treating an initially diagnosed cancer or treating a recurrent cancer after radiation therapy. That's another situation where that can be done, but it's just so critical to select patients well to ensure they have a good outcome.
Thank you. I think this was covered in the presentation, but just briefly, what is low risk prostate cancer? And can you clarify, I think this is referring to the screening guideline, or first degree relative at 65 years old. What does this mean?
So first degree relative would be a father or brother, rather than an uncle or a second or third degree relative. So someone just in that primary circle. And a low risk prostate cancer is something that on a biopsy, one would find what's called a Gleason 6 prostate cancer. So the cells would have a certain appearance where we would know that they would be a slow growing type of prostate cancer. So you only know that a prostate cancer is low risk after doing a biopsy and having the prostate tissue evaluated in the laboratory.
Okay, next question. BPH is a different condition than prostate cancer, but can BPH lead to, or can it be an indicator of potential prostate cancer?
I'll tackle that one again. I think one of the confusing things about this is that both of those processes, BPH, which is benign prostatic hypertrophy, so it's the growth of the prostate that I talked about that occurs with age, and prostate cancer, as Dr. Hyams alluded to, both these things actually are increasingly common in men as we get older. So I tend to think of them as things that sort of, they go together, but it doesn't necessarily follow automatically that one means you've got the other. Many, many men seeing a urologist, dealing with symptoms of BPH, will somewhere along the way get found to have a prostate cancer. And they'll ask me all the time, was my BPH telling me that this was going to happen 2, 3, 4, 5 years ago? And I tell them almost always, no, I really don't think so. I think that's just a symptom that happens to us, an event that happens to us as we get older. But then unfortunately, so can prostate cancer.
Okay. What are the symptoms of advanced prostate cancer, and how often should men get screened?
So symptoms of advanced prostate cancer vary. So if it's a locally advanced cancer in the pelvis, there can be obstruction of urinary flow, there can be blood in the urine, there can be obstruction of the kidneys where the kidneys may not work normally and one can develop flank or abdominal pain. One could, in theory, develop weight loss, decreased appetite, or pain in the bones where there may be bone involvement. So all of those are more sinister signs of a more advanced prostate cancer. In terms of the frequency of screening, this is a subject of sort of active debate and active study in urology. We don't want to over-screen men, have them come in more often than they need to, but we don't want to be under-attentive also. So men who are at the lowest risk, who have a very low PSA at their initial screening, let's say at age 45 or 50, don't necessarily need to be screened every year. That's a very case-by-case decision that's made with the urologist and the patient. But those men can more safely have screening every other year or perhaps every 3 to 5 years. For men who have any risk factors or have a modestly elevated initial screening PSA at age 45 to 50, those men should really be followed on an annual basis. So, unfortunately, it's not a one-size-fits-all approach, which makes it more complicated. But the benefit of that is that it's individualized and tailored, sort of almost precision type medicine, where you can have the right sort of approach devised for you with a urologist who is savvy about this, to again optimize the intervals for screening to keep you safe.
Okay, many questions still to answer. Does diet play a role in who gets prostate cancer or who gets cancer? I think this is a prostate cancer in this case. Do you find vegans or vegetarians get this type of cancer less than those who eat meat? And have there been any studies?
I can answer that succinctly. So there are some associations between certain diets or certain food consumption and risk of prostate cancer, but the evidence is not sufficient to say one should follow a vegan or vegetarian diet. The associations are higher risk in large populations among people who consume a high volume of red meat and saturated fat. Also, there seems to be less risk in people who consume more fruits and vegetables, particularly tomatoes, which contain a chemical called lycopene, and soy-based products like tofu or other products in that family. So those are just associations, but those are certainly things that someone can do to sort of control what one can control in terms of risk.
Okay. This is a question. I am 31 years old, but I have symptoms which I can describe that lead me to believe that I might have a benign or cancerous tumor in my prostate. At 31 years old, could I be checked out for this at my current age? That's the question. I was talking to a doctor's assistant a week ago who was reluctant to check at first due to my age. I am also planning on getting a vasectomy soon, so I was planning on seeing a urologist anyway. So I think the question is, can someone with this with symptoms be checked at 31?
I would tell that person that at his age, it's not yet reasonable to think about doing PSA testing. Men in their early 30s, it really is extraordinarily unlikely for him to have a prostate cancer. It's very reasonable, given his symptoms, to do a finger exam of the prostate. I don't think that's crazy if he's willing to undergo that. And that could be done at the same time that he sees a urologist to talk about the vasectomy he wants to get. It's very possible that examination will reveal something that could explain his symptoms, and that revelation may very well not be prostate cancer.
Thank you, Dr. Alukal. Next question, what happens when a patient doesn't produce enough testosterone? Is he at high risk?
I'll tackle that. There's a lot of data that's really confusing that points in both directions. Questions of whether or not a man's testosterone levels put him at a higher risk of prostate cancer, and could a low level make you more likely to have prostate cancer? Could a high level make you more likely to have prostate cancer? And I would just tell people that, the jury is out. We understand that there's an association between testosterone and prostate cancer, insofar as when people have an advanced prostate cancer, that's spread, one of the best ways we have to put the brakes on for that prostate cancer, not to cure it completely, but to really slow it down a ton, is to turn off a patient's testosterone completely, to give him a testosterone level of 0. And that slows down his prostate cancer. So we know that there's something about testosterone that enables the growth of prostate cancer. But we don't know in the younger man whether or not a man with a testosterone level that's higher than the next man is more likely to automatically get prostate cancer, or aggressive prostate cancer, or prostate cancer at a younger age.
Thank you. This one is about vitamins. There's a question, are there vitamins that you can take to help your prostate remain cancer-free? And another question related to that, do any of the urologists have professional recommendations regarding taking supplements such as saw palmetto, and that's sitosterol for prostate health?
Sure. I would echo what Dr. Hyams said before. The only dietary change I've ever seen real data for that suggests that consuming more of fill in the blank lowers somebody's risk of prostate cancer is, again, lycopene. And as he alluded to, you find that most likely in cooked tomatoes. There's an awful lot of questions out there about vitamins and supplements and not a lot of good data. And I actually oftentimes point out to people, there's prostate supplements people take all the time that might have in them selenium or zinc or vitamin E, specifically because these things are thought to help with the prostate function. But actually, there is a very, very good study that was well done, designed to try and look at selenium and vitamin E and their ability to prevent prostate cancer. And that study in thousands of men showed the opposite. The men receiving selenium and vitamin E were actually getting more prostate cancers to the extent that they stopped the study. And so I'm always reminding people, look, we don't fully understand what the impact of many of these vitamins and supplements are. So maybe we should be careful or judicious about what we put in our bodies. Saw palmetto is a very specific one, and you know, the history of saw palmetto is that the Seminole Indians in Florida, they knew this plant, they ate the fruit, they made tea from it, and it did appear to help men as they aged with urinary symptoms or symptoms associated with prostate health. But I think the hard part is knowing which supplements out there have meaningful amounts of saw palmetto in them, as opposed to other compounds that could just be having some medicinal effect on the prostate. And it's hard also to know how does the substance work and what are the safety or side effect issues that you have to worry about with it.
Thank you. Should we try to take a few more questions, Calvin? I think we have about 7 left.
Okay, we can take about 4 more questions, I guess, and close it out.
Okay. Okay, this is a question that has come up twice. Is frequent trips to the restroom, sorry, let me read that again. Frequent urination, is that a sign of a symptom of prostate cancer? And what is the most important proactive step besides health screening?
Yeah, I mean, urinary symptoms like frequency or a weak stream are more likely in an aging man to be related to BPH or benign enlargement than prostate cancer. But you know, as we've mentioned, there's an overlap in risk. So aging men have risks of both BPH and prostate cancer. So I think having, you know, a discussion with the urologist about risk is really important, and how to manage symptoms, how to understand the underpinnings of those symptoms. So, you know, there are definitely tests that can be done to see why a man's having frequency. It may just be drinking too much coffee. It could be an enlarged prostate or an overactive bladder. There's a chance, albeit small, that it's an early sign of prostate cancer. But again, that man may have some ongoing risk just based on being, let's say, a 65-year-old man, and maybe hasn't had recent screening and would benefit from that. So there's some overlap there, but typically not causation. And in terms of what can a man do proactively, again, other than, you know, sort of some of those overarching things with diet that one would want to do anyway for cardiovascular health, just being engaged with your doctor in discussions of risk, and potentially seeing a urologist for anything that would indicate increased risk. I mean, that's really what you need to do.
Okay, thank you. And if this is the next question, if you have had a physical and your percent free PSA is 35.7%, should you be concerned?
I'll take that one. You do have to put it in the context of the patient's total PSA, but a higher percentage free PSA is good. Okay, so free PSA we tend to think of as really only being meaningful if the patient's total PSA happens to be between the numbers 4 and 10. But if that were the case, a free PSA with a percentage of 30, 35, 40, that would be a good number. So it speaks to a lower risk of prostate cancer. Can't guarantee that that means that the patient's at no risk of prostate cancer. So I'd want to see all those numbers in order to be able to reach a conclusion about that.
Okay. I think two questions left. When your primary care physician does a digital rectal exam, is she able to accurately identify whether the patient is starting to have signs of prostate cancer?
So it's just one piece of the puzzle. So an exam by itself is going to be insufficient, but it's going to add information. As Joe mentioned earlier, it's sort of complementary to the PSA and understanding a man's risk. It's true that sometimes men with lower PSAs can have prostate cancer. It's not common. That certainly can occur. And a bump on the prostate may be a sign that can be detected to enable an early diagnosis. So I think that it's an important tool for evaluation. The other thing is that when men have an elevated PSA, it could simply be related to prostate enlargement, larger prostates, more cells, higher PSA level. Knowing the size of a man's prostate from an exam, which is the other piece of information you get from an exam, can help you understand if that elevation is more likely from benign enlargement or rather a cancer problem. So I think it's very useful, gives useful information, and is necessary but not sufficient.
Thank you. I think last question, does having an STD in the past increase risk of prostate cancer?
Not to my knowledge.
Calvin, I'll turn it back to you.
Well, we have one slide that gives our contact information in case someone wants to get in contact with the center. You will see the email address, phone number, website, and tweet. Not that one. That's the one. So if you want to take a snapshot of that, we would appreciate that you do that and get in contact with us if you think you need to get additional information. If you would like to have this program presented to a group that you belong to, we'll be happy to do so. I would like to personally thank all the participants, those who presented tonight, for a well-designed program. The information was great. It was informative and educational. Also, I'd like to thank those who listened in tonight, who took the time to listen in tonight. And just so that you know, I just had a couple of texts where some men are telling me that they're going to make an appointment tomorrow. So that means we have been effective. Thank you so much. That concludes our presentation. Take care. Calvin. And again, thanks.
Thank you. Thanks for having me.
Special thanks to Calvin and for his leadership on organizing all of this and to all the excellent information from the panelists. If you can just in the chat room, thank Calvin and all the panelists, and thank you so much for your time tonight.
Thank you.
Thank you.
Thank you so much.